Assalamu alaikum. Good afternoon, everybody. I am Abdul Malik Al Yahya from second year resident from King Khalid Eye Specialist Hospital. I'm happy to present this case. A 40 years old female is complaining from unilateral right ptosis for 1.5 years. She's also complaining from attacks of unilateral right periocular and deep ocular pain, upper lid swelling, conjunctival redness, and tearing, lasting for 1 and 2 days, then resolve. She experienced these attacks nearly every month. She is known to have multinodular goiter for 7 years. She denied any symptoms of right facial anhidrosis, proptosis, diplopia, dyspnea, or dysphagia. On a clinical examination, right upper lid was ptotic by 2 millimeter. Pupil examination shows anisocoria with a 2 millimeter difference, otherwise the examination was normal. After installation of apraclonidine for both eyes, patient showed reverse anisocoria and resolving of the ptosis. CT scan and MRI confirm that there is second order neuron Horner syndrome caused by the compression of the thyroid nodules to the sympathetic chain. Medical report was given to the patient advising for thyroidectomy, and the patient has undergone radiofrequency ablation. 6-month follow-up shows no improvement. Here is the picture before and after installation of the apraclonidine. And here is the compression in the common carotid. Thyroid neoplasm known to cause second-order neuron Horner syndrome with a prevalence ranging from 1 to 8%. According to the recent Horner syndrome review article, second-order neuron usually present with ipsilateral ptosis, meiosis, and facial anhidrosis, while third-order neuron could present with a cluster headache and without symptoms of anhidrosis if the compression is superior to the carotid bifurcation. There is also another entity called Ryder syndrome, which is a third-order neuron Horner syndrome characterized by unilateral headache and periocular pain with hyperemia and lid swelling without symptoms of anhidrosis. So in this case, we have second-order neuron Horner syndrome associated with trigeminal autonomic headache without symptoms of anhidrosis. There is only one case report found in the literature with the same presentation. For our patient, we have she done radiofrequency test. A short-term study, 1 to 2 years follow-up, showed that it is effective to reduce 50 to 80%, and some patients need more session of thyroid radiofrequency. And there is a case report showed that long-standing compression of the oculosympathetic chain may cause irreversible Horner syndrome, which is maybe what happened to our case. So my question, if the patient is happy and improved with the topical treatment, for example, like brimonidine, will you go for surgery or not in terms of ptosis? And the second question, what is the best modality, surgical option to treat these patients?
I would go ahead with ptosis because I want to relieve the patient of her symptoms, and I personally do external approach.
I would go for ptosis surgery because it's not improved after the treating the thyroid, and I think I might go for Dr. Richard Allen is here, his way of doing molar conjunctival resection.
We have pediatric ophthalmologists in the crowd, right? So any resident pediatric fellow, just put up your hand. They have another session. Who's the lady who just finished a fellowship at Cape Town? Was awarded yesterday. There you are. So good. I follow. So if you had a 2-year-old child who presented with a new onset Horner syndrome, what should you be worried about if you're a pediatric ophthalmologist? This is very good for most of the people. What tumor are you thinking about? And which part of the body you're talking about? All right, typically what would a 2-year-old develop, which causes an Horner syndrome at that age group? You're not allowed to answer. Yes? Cervical neuroblastoma, exactly right. So if you had an adult patient who had a painful Horner syndrome, what should you be thinking about? No, you're not allowed to answer. There's somebody there. What? Sorry? Neck dissection? No. Carotid dissection. Yes, it's in the neck here, but it's not neck dissection. Absolutely as well. So my question to our panelists here is that we're talking about ptosis correction, but we have not solved the problem, which is causing the etiology of the problem itself. No, they just did a radio frequency and didn't improve.
Radio frequency.
Only radio frequency is shrinkage of the thyroid, but the Honor syndrome did not resolve. So the question is now, would you recommend a thyroidectomy for this patient? Treat the problem first.
I need to ask the expert on this because I'm not supposed to recommend treatment for thyroid tumor myself as an ophthalmologist. So,
people in the audience? Well, when it comes to experts, you can talk. Go ahead now. What would you recommend? So, show of hands. Now we know we have proven that it's an enlarged thyroid which is compressing in the carotid and the cervical sympathetic, which is causing the honors, which is not resolved with the radio frequency.
Yes.
So would you recommend the surgical endocrinologist to go ahead with the thyroidectomy? Right. And how many of you agree with that? So what have you, 1, 2, 3, 4, 5, 6. How many of you should say that, no, we should fix the Honor syndrome first? Right, so does that answer your question?
Yeah.
And just out of curiosity, Richard gave a beautiful talk today. This is Honor syndrome. Assuming the primary etiology has been taken care of, how many of you would do an anterior approach ptosis surgery? Just show of hands. No, you have to show your hand. Anterior approach, anybody in the crowd? So one. How many of you would do a posterior approach? Interesting, yeah, great. So could you share your experience in 30 seconds, anterior approach to Honor syndrome?
I must say I haven't done many Horner syndrome, but my approach to ptosis is usually anterior because I believe in our area with a lot of dryness and irritation, you shouldn't touch, really violate the conjunctiva. And this is something I've been doing for 30 years.